Okay. All right, let's go ahead and get started, shall we? So thanks everybody again, and I'm going to hit start webinar. Okay, welcome everybody. Come on in and get situated as we see some more people flowing in from the attendee side. Welcome again to the latest installment of the virtual symposium by the amazing Meredith A. Cowden Foundation. This is the 2022 Graft versus Host Disease Virtual Symposium Part 1. Before I pass it over to Jerry Cowden to give the introduction for our amazing speaker of this Part 1 of today, just wanted to go over some technical information. As a reminder, you're unable to speak as an attendee, so please put any questions into the Q&A area for our amazing presenter and presenters on our panel for Part 2, as well as feel free to use the chat as well throughout the presentation. This will be recorded, so if you want to come back to it, we will pass over the recording to the Cowden Foundation to have that ability for people to check out. And with that, if you have any issues or questions at all throughout, feel free to contact myself directly by clicking on my name, Nick Galarakis. I'll be happy to help you out there. And with that, Jerry, I will pass it over to you, sir. Oh, Jerry, you are muted.
There, that should be better. Welcome to the 12th Annual GvHD Symposium. My name's Jerry Cowden. I'm the founder and president of the foundation. And I am very pleased, we are very pleased to have Dr. Koreth as our presenter today. You will hear his biography a little bit later. In March of this year, we celebrated our 16th anniversary of the Cowden Foundation. There was no party or anything, but we had just a milestone pass. We are the only foundation that concentrates solely on graft versus host disease, otherwise known as GvHD. We're pleased to have the list of presenters that we have had in the years. There's a list of them on our website, and I think you will find them very, very impressive. In order to do these symposiums, we need three things. We need volunteers, volunteer physicians, and money. And without further ado, I will give you the background. Our sponsors that have presented and signed on to help us financially and in other ways are as follows. In the hospital category, we have the Cleveland Clinic, and in the Edgar James the Cancer Institute at the Ohio State University. For this year, for the first time ever, we have an annual year-long sponsor, which is Sanofi. The program sponsors are Syndax, Pharmacyclic, and again, Sanofi. Finally, our keynote speaker sponsor is Insight. Insight has been with us since 2012. We couldn't do or maintain the program without their financial support. Secondly, our volunteer doctors who help design the program and recruit speakers and topics are as follows. Dr. Steve Pavletic from the NIH, Dr. Matt Colascio from the Cleveland Clinic, Dr. Betty Hamilton from the Cleveland Clinic, Dr. Annie M. from the University of Pittsburgh Medical Center, Dr. Marcos de Lima from Ohio State University, Dr. Hannah Cho from OSU, Dr. Hing Liu from Moffitt in Orlando, and Dr. Ken Cook from Johns Hopkins. I'll wrap this up with welcome. We appreciate you attending, and I'm going to turn this over to Dr. Steve Pavletic, who will introduce our main speaker.
Thank you, Jerry. Thank you, everybody, for being here today with us for this first seminar of this year GvHD symposium. And my great honor and task for today is to introduce on the behalf of the planning committee our speaker for today. And this is Dr. John Koreth, a hematology oncology attending and physician in bone marrow transplantation at Dana-Farber Cancer Institute. Dr. Koreth is as well the associate member of Brigham Women's Hospital and professor of medicine at Harvard Medical School. Dr. Koreth is as well as a friend and colleague of many years that we've been working together in the bone marrow transplant and research community. This is why this presents such a distinct honor and joy to have him here with us today. Dr. Koreth is a graduate of the University of Delhi, India, and Oxford University in UK. He trained in internal medicine at Brigham and Women's Hospital and hematology oncology at Dana-Farber Cancer Center. He completed postdoctoral research training with Dr. Stuart Orkin at Dana-Farber and Sander van den Heuvel at Massachusetts General Hospital. Dr. Koreth's clinical and translational research seeks to optimize bone marrow transplant utilization in various hematologic malignancies, including multiple myeloma, acute myeloid leukemia, and myelodysplastic syndromes, and in particular to improve outcomes in advanced aggressive hematologic malignancies with a special focus on graft versus host disease and immune modulation and immunotherapy strategies for control graft versus host disease as a major transplantation barrier and toxicity. His seminal work on augmenting anti-inflammatory regulatory T cells also has implications beyond graft versus host disease itself in the other areas of transplantation and beyond. Dr. Koreth, many honors include a Rhodes Scholarship, Claudia Adams Bard Award, Dunkin' Donuts Rising Star Award, American Society of Transplantation and Cellular Therapy New Investigator Award, Leukemia and Lymphoma Society Scholar in Clinical Research Award, and he is a member of the American Society of Hematology and ASTCT, where he is engaged in a number of initiatives and committees. Therefore, it's my distinct honor and pleasure to announce his talk today. The title is Immunotherapy for Chronic GvHD. So, Dr. Koreth, thank you for being with us, and the stage is yours.
Thank you so much, Steve, for that very kind introduction. And my thanks to the Countman Foundation for inviting me. It's truly a pleasure. I did have an opportunity to see the list of previous speakers, so it's very gratifying to see such an eminent list and thankful to be invited. With that, I will share my screen and I will try to get going with the presentation. Give me a second just so I set everything up. I hope everyone can see my screen and the laser pointer. So thank you once again. I'm trying to focus my presentation on certain aspects of chronic GvHD. Obviously, this is a distinguished and expert audience in many regards, but I'm trying to be a little bit broader in case there are patients and family members and folks who may not have grappled with some of the complexities of chronic GvHD. So my title is IL-2 based Treg or regulatory T cell therapy for chronic graft versus host disease. These are my disclosures. A lot of my work is in clinical translation, so that involves, of course, support from our pharmaceutical partners, which I'm happy to acknowledge here. I also acknowledge that we are describing the off-label use of interleukin-2 in graft versus host disease, and that I do have some IP in the space of low-dose IL-2 for the management of GvHD and other disorders of immune inflammation. So this audience probably doesn't need to hear this, but this is kind of a standard background. I'd like to have everyone just be on the same page for this talk, which is to say chronic GvHD is obviously a major transplantation complication, toxicity, barrier, you name it. It is a multi-system immune inflammatory disorder. It has a very prominent fibrotic component, which actually distinguishes it from acute graft versus host disease, which is similarly named, but has a somewhat different pathology. Chronic GvHD is a major cause of morbidity and mortality after transplantation. It impacts over half of transplant survivors and has quality of life impacts similar to living with major autoimmune diseases like lupus and MS. Outcomes, I would think it's still fair to say that chronic GvHD outcomes still remain suboptimal. Everyone uses upfront steroids, albeit recognizing they have somewhat limited utility and considerable long-term toxicity. We do often add additional immune suppression, which can in some case benefit, and indeed we have FDA approvals in that regard, but these interventions typically increase the risk of infectious non-relapse mortality, basically death from infections, for instance. So I believe that novel immunomodulation, not necessarily immunosuppression, so immunomodulatory therapies are an ongoing real need. This is a slide somewhat complex. The disease is complex, describing the etiopathogenesis, the molecular and immunologic cellular mechanisms underlying the development of chronic GvHD, recognizing that these immune cells can come from the donor graft. They can also arise from the donor thymus as sort of thymic neogenesis. This involves both the T cell axis, all the T cells are out here in purplish blue, as well as the humoral axis or the B cells that then produce pathogenic autoantibodies. Both of these interact in the lymph nodes, these two arms of the immune system, as well as in the target tissues via the peripheral blood. And in here, the production of these antibodies, for instance, can be directly stimulatory to the fibrotic process, but also there can be tissue injury from the T cells and ultimately the recruitment of macrophages, which underlie the production, for instance, of TGF-beta, which is this communication molecule, so to speak, that tells the fibroblasts to proliferate and produce more scar tissue. And of course, that can involve a plethora of organs, including the lungs and the skin, as shown here. What I want to emphasize here, which is somewhat underappreciated if you just look at the complexity of this image, is that there is this population of cells called Tregs, or regulatory T cells, which may be present in the graft. They may be produced from the thymus, and they may actually arise even from the effector standard T cells. And what these cells can do is they can block multiple aspects of this pro-inflammatory cascade, both at the level of the T cells, but also, interestingly, at the level of B cells, for instance, at the level of what's called the GCB reaction of the lymph nodes, which is the training, targeting, and activation of pathogenic B cells that then subsequently produce autoantibodies. I will spend a few minutes talking about these regulatory T cells. What are they, and what are the implications of their presence or absence? So these are what's called CD4 positive T cells. That is a subset of the T cell population. More specifically, they are 5 to 10% of the CD4 pool. They are characterized by the presence of CD25 high, and I'll come back to that later, as well as this intracellular transcription factor called FOXP3, which actually drives their development into this lineage. They act normally to dominantly suppress autoreactive lymphocytes. So here's, for instance, a schema that shows that if you do a transplant from a normal mouse in the right balance of regulatory and effector T cells, you can actually recover normal immune function in a T-cell deficient recipient. If you were to selectively deplete the Treg and only put in the effector T cells, the animal results in the recipient animal has an overactive immune system that puts them prone to autoimmunity, inflammatory bowel disease, for instance, as well as enhanced anti-tumor responses. And if conversely you increase the proportion of Treg in that particular process, you can actually have a generalized tolerance wherein a third-party graft, shown here by the black fur, is indeed acceptable in this mouse model of transplant. So they do act naturally to control both aspects of what's called the innate immune system as well as the adaptive, that is the T and the B cells, immune responses, and actively maintain tolerance in a normal individual. How do they do that? There's several complementary mechanisms. These can all be active. A very dominant mechanism is thought to be the physical depletion or killing of effector T cells directly by basically poking holes in the cell membrane using these granozymes and perforins. They can also target the immune synapse, the place where the antigen-presenting cells activate T cells, and by their inhibitory interactions, they can prevent the activation of T cells. They can also produce inhibitory cytokines that actively calm effector T cells, and then selectively by depleting cytokines and metabolites in the environment can actually, quote unquote, starve, metabolically disrupt an effector T cell. So multiple overlapping mechanisms allow them to be dominantly suppressive of T cells. Final cartoon schema is to show that just like a naive effector T cell is derived from the thymus and goes through all of these steps of activation in the periphery, transformation into an effector and tissue resident and central memory T cells, and these can all sort of transfer from one phase to another. Similarly, a regulatory T cell is produced prominently from the thymus. It then encounters antigen in the periphery to become an activated regulatory T cell, which can then have calming effects on these effector T cells. And finally, that there is this process of what's called peripheral conversion, wherein a naive effector lineage T cell can sometimes transform into a suppressive regulatory T cell rather than an activated effector T cell. So multiple mechanisms, very analogous between the regulatory T cell and the effector T cell compartments. So where does transplant fit into all of this? So this is work now going back over 15 years where folks in the Dana-Farber and Jerry Ritz's lab showed that when we look at patient samples and we just look at the readout of FOXP3 levels in the blood as a surrogate for the amount of regulatory T cells, since FOXP3 is that transcription factor that defines a T cell as a T regulatory cell. Patients who have been through transplant without GvH, patients who are healthy and have never had a transplant, have a higher level of circulating FOXP3 than patients with active chronic GvHD, suggesting that active GvHD is associated with fewer circulating Treg cells. And indeed, this is thought to be an important mechanism in not just the presence of a GvHD, but in the causation. So I'm summarizing multiple publications, but what we have shown is that post-transplantation in adult recipients who go on to get graft versus host disease, a primary lesion immunologically appears to be in their thymus, wherein post-transplant they are able to produce effector T cells, but the thymus is poor at producing regulatory T cells. The few regulatory T cells that are in the periphery for a while actively proliferate to kind of compensate for the lack of fresh recruits, so to speak, but that this is an unsustainable process, and at an average about 9 months post-transplant, these cells basically peter out. They poop out, they die, and then their absence results in the development of chronic GvHD. So that then places the regulatory T cells somewhat in the middle of the effector T and the effector B cells. So if we think about rational therapies for GvHD, we have now, of course, approval for JAK inhibitors and ROCK inhibitors that predominantly act on alloreactive or proactive T cells. We also have approval for B cell inhibition, such as ibrutinib, that primarily inhibits autoreactive or alloreactive B lineage cells. But that potentially these regulatory T cells, by their capacity to suppress both the T and the B axes, could indeed be an important component. And therefore, we are looking at ways of augmenting them with a focus on in vivo, in-patient Treg expansion using this cytokine called low-dose IL-2. So what is interleukin-2? Interleukin-2 is old-fashioned stuff. It's a cytokine that was identified back in the 70s. It was cloned in the early 80s and was actually FDA approved as a cancer therapy over 25 years ago, actually 30 years at this point. And really what it is that at high doses, IL-2 can actually activate and stimulate effector T cells to kill cancer. However, we're not doing it to kill cancer. We're doing it to control GvH. And why does that work? That works because the IL-2 receptor is how IL-2 affects immune cells. And the IL-2 receptor is what's called a heterotrimeric receptor. There's 3 different protein components. There's a common gamma chain, there's a beta chain, and there's an alpha chain called CD25. And turns out that regulatory T cells constitutively express what's called the high affinity CD25 subunit, resulting in the presence of a heterotrimeric receptor constitutively in these cells. So they are primed to respond to any IL-2 that's in their vicinity. They suck it up, they immediately respond, and they actually do not require a second signal, which is the T cell receptor, to actually respond to IL-2. So they importantly do not produce IL-2. So while they're exquisitely responsive to any IL-2 around, they need other cells or an exogenous source of IL-2 in order to be able to be activated. Effector or conventional CD4 T cells only express these two, the beta and the gamma chains constitutively, not the alpha chain. So they have a lower affinity for IL-2. They temporarily express CD25, the alpha chain, when they are activated. So if they are not activated, they do not have a high affinity receptor. They also need a second signal, such as the TCR signal, so second receptor signal, in order to respond. Importantly, however, they produce IL-2 after they're activated. So you have this paradigm where the effector T cells make the IL-2 that then the regulatory T cells ramp up and bring the inflammatory response down. So it's a nice negative feedback control loop. So in principle, if you brought in low-dose IL-2, you would have Treg cells that are primed to respond in a way that the effector T cells are not. And so we ended up doing a study now over 10 years ago, where we said we know that high-dose IL-2 is used to activate effector T cells and kill cancer, but at low doses, we expect the results to be opposite, that they would actually activate the anti-inflammatory regulatory T cells and control immune inflammation. So we did a phase 1 study in patients with advanced relapsed refractory chronic GvHD. We were able to show that indeed using this at low doses, up to 1 million units per meter squared per day of body surface area, was safe. And at least in the first 25 patients treated, about half of them had a substantial, meaningful response to this treatment with no flares of GvHD and no malignant relapse, 2 major concerns at the time of this phase 1 study. We went on in a phase 2 study to show that in an additional 30+ patients, that we were seeing again something in that 50 to 60% rate of response. We did see 3 patients with progression of disease. I will say this was sort of a progression of their natural trajectory, not a flare kind of acute exacerbation in the setting of treatment. Nonetheless, this is clearly not a perfect therapy, albeit it may be a good one. And immunologically, what we were able to show both in the phase 1 and the phase 2, almost essentially the same thing, is that we had a very significant increase in red here in the circulating regulatory T cells, starting from a very low subnormal number to a supraphysiologic level that was sustained throughout the 8 to 12 weeks of treatment, but then declined if we stopped the treatment. And indeed, if we look at the ratio of the regulatory T cells to the effector T cells, sort of if you look at a sort of balance switch, if you like, of saying how pro-inflammatory versus anti-inflammatory any one patient might be at a given time, again, we saw a very substantial increase to about 30 to 40% of their circulating cells were now regulatory T cells. So they were moving in an anti-inflammatory axis, so to speak, for the 12 weeks of treatment in phase 2 and then coming down off treatment. We did see another lineage called NK cells also go up, with this treatment. NK cells are thought to potentially have an anti-leukemic effect. So we didn't necessarily think of this as a bad thing, but it's clearly something to continue to keep an eye on. So these two studies were really rather replicative of each other. When we looked deeper at what was happening in the regulatory and the conventional or effector T cell compartments, what we discovered and published now about 10 years ago was that this was not just the proliferation of pre-existing circulating regulatory T cells. So if you look at a proliferation readout such as Ki67, yes, indeed, there was a preferential proliferation and expansion of pre-existing Treg within the first 2 weeks. However, in the later weeks, in weeks 4 through 8 of this 8-week course of treatment, there was actually an increase in thymic neogenesis. So these are new Tregs that are being produced by the thymuses of these adult patients, as well as a later marked increase in the presence of survival factors, anti-apoptotic factors such as BCL2 within the circulating regulatory T cells. So we seem to be impacting major aspects of regulatory T cell biology beyond just a simplistic growth factor proliferation story. Indeed, when we looked at patients now at extended therapy, in our trials, we allowed patients who were benefiting from this 8 to 12 weeks of treatment to go on extended treatment for as long as the treatment was beneficial. And what we discovered was during this extended phase, that the regulatory T cells, in this instance for up to 2 years, now we have data much beyond that, that the expansion and augmentation of their circulating Tregs was indeed substantially durable, that there was over time a decline in the Treg to Tcon ratio, that so-called rheostat of balance between pro and anti-inflammatory cells, but that was not due to the drop in regulatory T cells, but actually a gradual recovery of the circulating effector T cells back to a more normal state over about 2+ years. And this may in part be due to the fact that we were actually tapering steroids during this period, and steroids can be lymphopenic, so they kind of deplete immune cells. Importantly, we also showed that we had some early predictors of who was going to respond to this immune modulation treatment. Specifically, we didn't find the number of regulatory T cells or their level of expansion, etc., predictive of response. Everyone seemed to increase their Treg cells. But what we found was that patients who were responders tended to have a higher Treg to T effector or Tcon ratio at baseline at study entry, as well as at week 1 of treatment. So they not just started higher, they often were able to respond with much more of a anti-inflammatory immune balance state at the end of 1 week, as compared to non-responders who started lower and often had suboptimal increases in the Treg to Tcon ratio at week 1. However, this also raised many questions for us, many scientific biologic questions, as well as translational clinical questions. Since all patients receiving this low-dose IL-2 daily shots have a similar quantitative increase in absolute Treg numbers, why do only half of them on average have a clinical meaningful response? And then, of course, what is the biology of this response? Is it that even though the Treg are coming up in all patients, that there are intrinsic differences? Are there different functional states of these Treg? Is it that the effector conventional T cells are somehow more resistant? We're not entirely sure. So here, for instance, is showing that between responders and non-responders, the absolute increase from baseline levels is very comparable. There may be some outliers here, but this is a smaller data set. So it turns out this difference, for instance, is not significant between responders and non-responders. The absolute Treg count doesn't matter so much. So we decided to look at this in greater detail using at least some available assays. So we undertook what's called an in vitro Treg suppression assay. It's basically looking at the capacity of these regulatory T cells in a Petri dish to suppress their autologous effector T cells. So we use this dye as these effector T cells in an unstimulated state. They're doing nothing. All the cells have the dye at a high level, and that's just where we are. If you then take these cells and you stimulate them to proliferate, using standardized CD3, CD28 co-stimulation, every dividing population will have a serial dilution of the dye, such that the fainter it gets, the further away it is as a daughter cell from the original cell. And when you do that, you get this number, 80% of the cells were dividing. If you then add a 1-to-1 ratio of regulatory T cells to the conventional T cells, you find that you're very substantially reducing the fraction of dividing cells. Now only 30% as compared to 80% are dividing. So with this, you can get some kind of a readout if you compare different populations of patient Treg added to donor Treg, added to donor T effector cells and vice versa. So using this readout, we actually said if we look at, for instance, healthy donor regulatory T cells versus the healthy donor TCON, you get a certain level of suppression around that 80% mark. If you then look at patient Treg with healthy donor TCON, what you see is at baseline, those cells are less suppressive. However, if you then look at 6 weeks of IL-2 treatment from that same patient Treg are now better able to suppress the healthy donor T effector cells. And the similar difference is seen if you look at patient to patient. So patient Treg are now suppressing patient T effectors, again, a very substantial improvement. But healthy donor Treg, of course, are not any different from baseline or week 6. And indeed, it turns out that the T effector cells from these patients at baseline or week 6 are not intrinsically more resistant to suppression by these patient healthy donor Treg, by the healthy donor Treg. So the lesion is not at the level of the T effector cells. They are not intrinsically resistant, but that the patient Treg are dysfunctional, and that can improve with IL-2. We then said, okay, so that's looking at bulk populations, but are there more subtle differences, and can we assess that using the sequence of the T cell receptor as a way to look more closely within the T effectors and the T regulatory cells? So how does low-dose IL-2 affect the diversity of the Treg versus the TCON and the CD8s? How are the clones looking at baseline? How do they compare with the dominant clones at 12 weeks of treatment? Are there differences in this parameter between the responders versus non-responders? So when we did that analysis, and this is data heavy, I apologize, what we found was that at baseline, if you do what's called a Hill's diversity index, basically you're looking at the entire repertoire of the TCR sequence. The more diverse that sequence is, it's like looking at a ecosystem. The more diverse the ecosystem is, the healthier it is. So when you have lower diversity, that's not a good thing. So when you look at the diversity of the CD4 Treg, you find that at baseline in chronic GvHD patients, the Treg diversity is impaired. It's statistically significantly impaired, but the TCON or the T conventional cell and the CD8 diversity is actually not statistically significantly impaired. So this seems to be the specific lesion where the TCR diversity is exclusively or selectively impaired in Treg cells. If you then treat them with low-dose IL-2, you can actually recover and improve and normalize that lack of diversity, specifically within the Treg compartment. There is no change in the diversity of the T effectors or the CD8s with low-dose IL-2 treatment. And indeed, at 1 year of treatment, that improvement is sustained, specifically in the Treg as compared to any other lineage. If you look at the correlation of what are the dominant clones at 2 different time points, if you look in healthy donors, turns out that the dominant TCR clones within the Treg pool, the TCON pool, and the CD8 pool are pretty stable in healthy individuals. If you look at patients with chronic GvHD treated with IL-2, there is very little overlap of what was dominant at baseline versus what is dominant within the at week 12 or week 6 of IL-2 treatment. This is different than, for instance, the CD8s or the CD4 TCON. And even more interestingly, if you look at responders versus non-responders and you say, what are the top 1,000 PCR clones that you can discover within their Treg compartment? So within orange are novel clones not detected at baseline. You can see that responders have a significant dominance of novel clones as compared to non-responders, where there's much more of the blue, which are clones that were present at baseline. So it suggests to us that patients with chronic GvHD at baseline have a somewhat of a paucity of Treg clones. That's why they have less diversity. At 12 weeks of treatment, there's an increase of cells in both populations, all increase their Treg counts, for instance, but the actual TCR diversity is much higher within the responders as compared to the non-responders. So that's great. We're getting some insight as to you need to bring in more diversity. How do we, however, enhance the clinical responsiveness? So we said, let's look at another immune modulation treatment that's called ECP, or extracorporeal photopheresis. Around the time we were designing this trial, one of the dominant thoughts of how ECP worked, ECP has been around for decades as well, people thought it also actually increased Treg. So we said, let's combine twice weekly ECP, a very standard way of giving that. Let's do 8 weeks of ECP alone. Let's add then IL-2 for another 8 weeks to the ongoing ECP treatments. And so we did this study. We treated about 25 patients using this approach. What you can see at week 8 here is that there was some response to the ECP alone. Not a surprise, ECP is known to have some beneficial effects, but that at week 16, we had many more responders as compared to week 8. Now, that doesn't prove, of course, that it's the IL-2 doing it, because maybe 16 weeks of ECP works better than 8 weeks of ECP. But when you look at the immune profile of what's going on, what you find is during the first 8 weeks of ECP, basically, if you look at the CD4 T effector cells, if you look at B cells, if you look at NK cells, most of the cell population you look at, they're actually going down compared to the start point. So we actually see a sort of depletion of all cell populations during 8 weeks of ECP treatment. And if you look specifically at the Treg, same thing. Not much of a change, but they were very low to start with, certainly no increase, as was others had postulated. However, when you start the low-dose IL-2 treatment, you see an increase in NK cells in green, you see an increase in these CD4 Treg cells, and some increase on the T effector cells. So if you look at the Treg cells, for instance, a very substantial jump, about a 4-fold increase within a week of starting low-dose IL-2, which is then broadly sustained, albeit a bit plateaued after the first 2 weeks. And if you look at the CD4 Treg to T-con or T effector ratio, again, that balance switches very much more into the anti-inflammatory, more Treg compared to T-con ratio at that 30% range also. So this led us to this schema where we said actually 8 weeks of ECP seems, if anything, to deplete the number of circulating CD4 and CD8 T cells. If you add ECP to that, starting from a low base, you actually get a very selective increase in the Treg cells. And overall, we hit about a 60+% response rate, very safe therapy, reasonable therapy, but not necessarily dramatically better than what we were seeing with IL-2 alone. So we then moved on to study number 4. We said, okay, how else can we improve the response rate? And one of the things that had struck us in one of our early analyses was that if you look at the actual number of Treg in green versus the circulating level of plasma IL-2 on treatment, so they're getting the same fixed dose starting at week 0, what you see is a rampant increase in the circulating level of IL-2 for the first couple of weeks, but then it actually comes down substantially as the number of circulating Treg cells increases. And so we said maybe what's happening is, yes, we've expanded these Treg cells, but now they're sucking up all the IL-2, and now these cells are semi-starved. They've eaten up all the IL-2 available to them. So what would happen if in that same patient, at week 2 and at week 4, we actually increased the dose of IL-2 we were giving them, such that there was more IL-2 to sort of feed the famished millions of circulating Treg cells? So we did this in adult and pediatric patients. We started at slightly different dose levels, less for the pediatric patients. We just didn't want to push it quite as much. We didn't know what the pediatric experience would look like. And so we pushed this up to about 1 million, and with the adults, we pushed it about to 2 million units, so about double what we'd previously shown was tolerable as a fixed dosing strategy. And we looked at responses at 8 weeks. And basically what we saw, I will note the pediatric patients do predominantly get bone marrow grafts. That is different from the adults. That's just a known fact. What we found was that we weren't seeing a lot of responses in the adults, to be honest. Part of it was it really wasn't very tolerable. We thought if there's more circulating Treg, maybe they'll suck up all the IL-2 and you won't have as many side effects. But actually, patients didn't like it. There were a lot of flu-like symptoms. People just felt very blah, and they didn't really want to stay on that higher dose treatment. For the kids who got less, it was much more tolerable. And indeed, their response rates, even at an early time point, were striking, 8+ plus, so 73% in this early assessment at week 8. If we push the treatment further in these responders, we did increase somewhat the responses in adults, but in the kids, we actually had really dramatic responses. This is a teenager. You can see this glazing. This is a very characteristic feature of chronic GvH, a lot of glazing and scleroderma and tightness that improved by 8 weeks, but actually by 6 months, the glazing had almost completely disappeared. This kid was very much more flexible and mobile than at baseline. And indeed, over 90% of the kids treated on this protocol had very meaningful responses with very substantial reductions in their steroid use over that 6 to 12 month period. And impressively, very nice responses in lung and visceral GvHD, which really have been bugbears in chronic GvH. These are the sites, if involved, really can cause a dramatic increase in mortality from chronic GvHD. Immunologically, when we looked, there were also differences. Despite the kids getting lower doses of IL-2, they actually had more dramatic increases in their Treg to Tcon ratio, suggesting that they were more primed to respond to IL-2 within a Treg augmentation paradigm, so to speak. The NK cell population, which we had shown in adults, goes up, and indeed in this population also went up, was actually much less increased in the pediatric patients. So pediatric patients seem to have less of an NK amplification, more of a Treg amplification compared to adults. This is also showing that these kids, their young thymuses work better, that they actually produce more Treg cells from their thymus as compared to the adults, who also make more on IL-2 treatment, but the kids make dramatically more. And finally, PD-1, which is a marker on regulatory T cells of cell survival and activity, as opposed to its standard aspect of being a marker of cell exhaustion in effector T cells. In pediatric patients, these levels were higher, suggesting, again, there was more stability and survival positivity in the pediatric Tregs that were IL-2 treated. And then finally, I'm probably coming to the end of your tether here, but this is our 5th and final study saying, how can we better do low-dose IL-2 treatment? And in this study, what we said is maybe one reason why we're not seeing 100% response rate, for instance, even though everyone's Treg go up, is that these Treg cells are just intrinsically dysfunctional. So maybe what we need to do is to go to their healthy donors and actually collect from them immune cells, select out preferentially their Treg cells, infuse those into their recipients with active GvH, and then give them IL-2 treatment, such that we're amplifying healthy cells rather than dysfunctional pre-existing cells. And using this approach, as outlined here, we selected from the donor these cells, enriched but not 100% pure for Treg cells. We infused them into the recipient with refractory GvH, and then we gave them 8 weeks of low-dose IL-2 treatment. So in these 25 patients, again, fairly advanced patients, several years into the onset of their GvH, many failed prior therapies, etc., including, I will note, some of these patients had failed IL-2 treatments in the past. We were actually able to show that this process works. We get a 26-fold enrichment of Treg cells using our cell selection approach, that this is safe. There was a major concern. People said if you're infusing donor immune cells in patients with chronic GvH that is active, you might actually make it worse. So we didn't see that. That appeared safe. And we saw a clinical benefit between 20 and 60%, depending on how you define it. So not as high as with IL-2 alone, but we do recognize that 6 of these patients, for instance, had failed IL-2 therapy. And indeed, in some of them, we did see a response, though not again for the majority of these patients. So overall, we felt it was a reasonable approach. Immunologically, if we look at this, again, we saw an increase in regulatory T cells over time. This, however, didn't look that different from our IL-2 alone treated patients. So adding in fresh, quote unquote, healthy Treg cells didn't make them more likely to expand. What we did see, and really this is where the money slide is on the right, is that if you look at the Treg population in terms of that TCR clonality or diversity, and you say which are the dominant clones at the end of week 8, did they come from the donor infusion or were they at baseline? What you see in the Treg population is the majority of the expanded, of the dominant cells at week 8 had actually come from the donor-derived infused cells. not from the pre-existing cells, which had in fact predominantly contracted as a proportion at week 8 compared to baseline. Whereas for the T effector cells, or the T-cons, it was half and half. Roughly half of the donor cells had expanded, half had contracted, whereas on the baseline, half had expanded, the rest had stayed the same or contracted. So there did appear to be a differential expansion effect on the donor infused immune cells. And so this is the study summary to say, yes, we can do this safely. What we do appear to see is expansion predominantly of these donor-derived cells. And indeed, we see responses, but again, it doesn't appear to be dramatically different than IL-2 alone. So in a final analysis, we said, let's put everything together. So in over 100 patients, adult patients, pediatrics is separate, over 100 adult patients now treated. Each individual column here is a patient. Each row is a site of involvement, so skin, joint, muscle, fascia, lung, liver, GI, etc. You can see that this 100+ patient population is fairly advanced. They're over 1.5 years from chronic GvHD onset, 2.5 years from time of transplant, a median of 4 sites of involvement, failed 3 prior therapies ranging from 1 to 9 failed therapy, predominantly moderate to severe chronic GvHD. So we looked at several things here. Number one, you can see from this population is a predominant involvement in skin GvH and joint, muscle, and fascia. That is not a surprise. Everyone has reported that. We did have a bunch of patients with lung involvement. Eyes and mouth was also fairly common. If we try to cluster these presentations in our populations, what we find is there's a co-involvement in most of our patients of skin and joint. There's, to a lesser degree, co-involvement of liver and genital involvement, which is a little bit strange, but I guess. Mouth and eyes go together, again, not a surprise. Lung seems to be different from GI. So this is just sort of clustering to say what patterns were we seeing. If we look at responses, we did expect to see skin and joint, fascia, and muscle responses. Indeed, in about 40% or 30 to 40% of patients, we were seeing nice responses there. We were struck by the fact that 20% of patients actually with lung GvHD had responses, and by responses, I mean improvement, which is important because this is a disease, lung involvement is a disease that has a 9-fold increase in mortality, and it's been very refractory to treatments. So anything that can help patients with lung involvement is a big deal. Liver associated with a 4-fold increase in mortality. So the fact that we were seeing 60+% responses in the liver was also gratifying, frankly, somewhat unexpected, but highly gratifying. If we then said, how do the patients do? How do patients who are responding to treatment do? What we found was, number one, IL-2 is not a panacea. In other words, the older you are, obviously over time, the less well you do. Getting IL-2 doesn't rejuvenate you in that regard. So patients less than 50 versus greater than 50, even if they're responding, do tend to do differently. Importantly, if we look at the involvement with baseline lung, liver, or GI, so these are sites that have greater mortality risk, what we found was if you're responding, your mortality risk is no different if you have or you do not have lung, GI, liver involvement, suggesting that IL-2 response neutralizes the negative impact of having these sites involved. If we look at predictors of response, what we see is gratifyingly and importantly, the sooner you start low-dose IL-2 treatment, the more likely you are to do well, both in terms of response and survival. So here in terms of response, what you're seeing is if you started in less than 2 years or 2.5 years, if you started before you have failed 4 therapies, etc., you have much higher rates of response. Not necessarily a surprise. If you have an effective treatment, the sooner you start, probably the better you're going to do. That's basically what we're saying. And then finally, if you look at the immunology of what's going on, for responders versus non-responders, responders in red, non-responders in black, there's really no difference in the expansion of Treg that you see with IL-2 treatments. There's perhaps a little bit of a signal where you may see a smidge more of NK expansion in non-responders versus responders, but this was not truly sustained. So I think it's a little bit preliminary, but in line with what we described for the pediatric patients having less NK expansion compared to Treg. And then very importantly, that initial predictor of the Treg to T-con ratio, that in patients who do not have a response, they tend to have a baseline lower ratio, and then they tend to expand below that 20% cutoff, whereas responders tend to be above that 0.07 or 7% baseline, and they tend to respond above that 20% one-week cutoff. And that's broken out here as well, where you say that partial responders tend to have the above threshold ratio at baseline, as well as an above threshold ratio at week 1, thresholds again of 0.07 and 0.2. So if I summarize my data here over a decade plus, over 100 plus treated adult patients, I think at this point we're comfortable saying that low-dose IL-2 is safe, it is tolerable. Our clinical response rates is in the 50% range in sum total, and as high as 90% in pediatric patients receiving low-dose IL-2. That IL-2 responders have good long-term survival, including if they have liver or lung sites of involvement. We find that low-dose IL-2 truly has a biologic impact in enhancing the homeostatic proliferation of Treg. It's not just proliferation, though. It enhances their activity. It enhances their survival factors like BCL2. Critically, it increases the capability of thymic production of new, diverse TCR Tregs, and that the earlier you start treatment with a higher Treg to T-con ratio, and we are able to then generate novel Tregs, all of these variables can predict for clinical response. I'm also gratified to say we now have a National Children's Oncology Group trial of low-dose IL-2 for pediatric patients with steroid-refractory chronic GvHD that is in active clinical trial development, and that this should be opening shortly. And finally, which I have had no time to discuss, is that novel IL-2 based therapeutics are truly a new paradigm for immune inflammation. This is not just chronic GvHD. It actually turns out to be a broader paradigm for the entire field of autoimmunity and organ transplantation. And with that, I will acknowledge that this is truly a group effort led in part by me, but with the active participation, collaboration, and support of my colleagues on the clinical side. On the lab side, I've highlighted individuals here like Jennifer Wangbo, whose work is actively under publication or has been published. We have an entire clinical research team, and we have collaborators nationally and internationally that help us to do this. And of course, none of this would be possible without the support of all the individuals listed here. And finally, nothing of this would happen without the active involvement, encouragement, and support of our many patients that we have treated over the years, to whom I'm extremely grateful. And with that, I'm happy to take questions. Thank you for your attention.
Okay. Thank you, Dr. Koreth, for this fantastic presentation. And please, podium is open to our panelists and anybody else in the audience, please.
Steve and John, thank you for this wonderful talk. I have two questions for you, if I may. One is, do you have a sense of how these cells traffic, or even if that matters, right? If they reach target organs or not? And the second question is, have you retreated patients, and how often, in terms of durability of your responses?
Well, so the first question is obviously a critical and extremely hard question to answer.
I know.
You know, we obviously talk about the peripheral blood all the time because that's easily accessible to us. By looking at that, we certainly are able to look at things like, you know, recent thymic emigrants. So you can do what's called a TREC analysis. So you can look at CD31 positivity as a surrogate readout. So we have some sense of at least what the thymus as a gland is able to do to produce fresh output in terms of Treg and T effector cells. But I agree with you. The critical issue is, how do we know that these Treg be so different as they may be in the peripheral blood? How do we know they're actually getting to the sites of involvement and actually changing the repertoire of the resident regulatory T cells or the T effector cells? And the short answer is we don't know. So we would love to be able to do biopsies, for instance, at sites of involvement. It would be wonderful to have lung and liver readouts, maybe bronchoalveolar lavages as a readout if we can't do routinely lung biopsies. As you know, that's a potentially dangerous procedure. Skin biopsies do sound plausible. I think for practical reasons, we have not been very successful at doing it, partly because you get such a patchy involvement in the skin often, and the responses are often partial. So you have certain areas that stay the same and areas that get better. So I never know what to pick as a baseline site and then what to look as a responding site. But honestly, I think we should just start looking. I think our patients are understanding enough of the importance of this that they would be willing, especially at a skin site, to do that. And we now have more detailed 10x based single cell RNA-seq, for instance, where we could do things like FOXP3 and TCR. And so we could start to get a look at that, but we haven't. I think, your second question, remind me what the second question was.
In terms of durability of responses,
so that's
and if
right.
you retreat.
Right. So that's an easier thing to say. We had in our earlier trials, we actually had a pause. We said for responders at the end of week 8 or week 12, let's stop the treatment for 4 weeks and see what happens. Clinically, what we saw was that patients actually started to feel their symptoms come back fairly quickly. And that got better the moment they restarted. In terms of durability, so at least in the early period, in the first few months, if you stop, it's going to come back. So my analogy is it's a little bit like insulin treatment for diabetes, that while you get it, it's dramatically better in terms of your blood sugars. But if you stop, you still, so the fundamental lesion of why there's less production of IL-2, I don't know, but it's clear that you need IL-2. In terms of durability, we now have patients who've been treated over a decade with low-dose IL-2. I can tell you that it's very durable, both in terms of responses and in terms of the immunology of response, wherein they do have persistent, enhancement of Treg recovery. We are starting to look at patients who over the years have dropped off of treatment because of fatigue, or they say, you know what, I'm doing great, I'm not sure I need it, so kind of have that stop. So we're trying to put that together, but I don't have data to tell you how that plays out years into treatment.
Thank you. Thank you very much. Steve, you have a few questions under the Q&A.
Yeah, please go ahead, read them.
Okay, so
no, I mean, Marcus or John.
Do you plan to try low-dose IL-2 as prophylaxis in high-risk patients with GvHD?
Oh, here it is, yeah.
So I think that sounds like a great thing to do. I think it's the obvious thing to do scientifically, because if you think that earlier treatment is better in terms of treating, then really the best should be prophylaxis. I think practically there are a couple issues around that. One issue is we don't necessarily know who is truly at high risk for chronic GvHD. Different groups have postulated different biomarkers. I think the biomarker field is much better established for acute GvHD than chronic GvHD. We, for instance, have said, low thymic production of Treg cells at 3 months and 6 months predicts 9-month risk of GvH, but others have not replicated that. So I hesitate to present that as a simplistic answer. So at one level, the practical issue is who are these high-risk patients and do we truly know who they are? I think the second issue is really a treatment challenge, which is the current formulation is low-dose daily subcutaneous shots of IL-2. It's like giving yourself a daily insulin shot. And you have to do this for weeks, if not months. And so I can imagine that it is problematic for someone, say at 3 or 6 months into their transplant, they're still, coping with all the many demands the transplant places on them, to then tell them that, you know what, now I want you to start injecting yourself every day for the next 6 months. There might be some resistance to a treatment that has potential side effects, local injection site reactions, some flu-like symptoms, this and that, when patients have not experienced that toxicity of GvH. So I think the practical answer is yes, we should do it. Perhaps we should do it with a longer-acting formulation of IL-2 than the native IL-2, which is a very short-lasting cytokine, needs twice daily, if not daily, injections sub-Q, if you truly want to up sustainably the IL-2 levels. There's a question about multiple myeloma. Maybe that's not specific for this presentation, so I'm going to move on. There's a question about the stem cell source. So will you comment more about stem cell source and how this may impact response? We don't know. I did briefly comment on the idea that bone marrow grafts were obviously typically used in pediatric patients. We don't have enough of a breakout of bone marrow versus peripheral blood stem cell grafts in adults. We do know the presence of bone marrow versus peripheral blood stem cell grafting does indeed act as a risk factor for the development of chronic GvHD. So I do agree. I think that probably younger kids with more active thymuses who got more of a bone marrow graft where there are fewer T cells in total compared to peripheral blood stem cells may indeed be better primed to respond to IL-2, but I don't know about adults how critical that is.
It's a great question. Any other questions or?
They seem to have disappeared from my list, so maybe they moved.
I can maybe bring something up while discussion is going on. Clearly that's been substantial experience with the low-dose IL-2 over the last 10 years or so, thanks to your efforts. So can you, and it's, of course, it's not an FDA-approved therapy. It's like most of the things that we have options still, unfortunately, in chronic GvHD, that's off-label. But people are interested in clinical experiences. So can you comment a little bit just on from the clinician side, any intricacies of administration in terms of, we know that patients with calcineurin inhibitors and sirolimus are excluded. It's a long-term administration of subcutaneous injections, and in this big realm, when is the right timing and who may be the right patient when we go over this? Yeah, I know.
Questions, right, Steve? So, you and I have been through this before. So the first thing I'd say is if you have a patient that you think might benefit from low-dose IL-2 and you want to know how to administer it, please email us. You can email me at Dana Farber. It's jkoreth@partners.org. You can look it up. I'm sure it's online. Just email me. I'd be more than happy to, forward you our pharmacy compounding specifics. The bottom line is, it comes in high-dose vials because that's its FDA approval. We actually dilute, so we actually reformulate it. We make a liquid formulation. We then draw out in kind of tuberculin-type syringes a daily dose calculated for each individual patient, which is largely based on their weight and height, so their BSA, 1,000,000 units per meter squared. And we then give them in a chill pack a 14-day supply, which they take home and they keep in the fridge, 2 to 8 degrees centigrade, so not in the freezer. And they take out one single-use vial at a time, and they do a daily sub-Q injection, which we do a teach on. It's just like teaching people to give themselves Lovenox or to give themselves insulin. And we give them a Sharps bin to kind of throw it away. And then every 2 weeks, they come in, they bring the Sharps container, we dispose of it, and we give them a fresh supply, 2-week supply, which they then take home and put in their fridges. So practically, that's how it works. But I will emphasize that, it is a challenge to get it approved. We are very eager to actually go for a registration trial in this indication. I actually think the data is mature at this point. Over 100 patients is actually more than the number of patients that were treated in the registration trials for Rezurock and for ibrutinib, for instance. But of course, the studies we have done are not registration studies. They're academic single-site studies. So we would love to be able to do these trials. To me, it should be considered ideally as part of upfront chronic GvHD therapy. Steroids plus low-dose IL-2, or even low-dose IL-2 in lieu of steroids would be a reasonable trial design. I think the way these trials will ultimately happen in practical terms is there will be a novel IL-2 molecule, right? There will be a novel IL-2 mutane, something that is long-acting. Maybe it'll be a once-weekly, maybe it'll be every 2 weekly. People will get a shot a week or every 2 weeks. That'll probably be the design of a formal study. But that study obviously is not something that is ready for FDA approval today.
Thank you.
But we have had success. So we have had patient providers talk to insurance and say, this is the data. This patient has failed, standard treatment A, B, C, and D. They really do need something, and we would like them to be approved to get. So I have had patients even get, off protocol treatment approval, and that's how providers reach out to me, and I'm more than happy to walk them through how this is compounded and disseminated.
Very good. I definitely think we could continue this discussion more. And we have the next section of the seminar is the Q&A, where a number of these things could be revisited. But I would like to thank Dr. Koreth for this perspective and outstanding presentation. It's inspiring, really showing how systematically approaching to a question, yields useful knowledge over years. And at this point, our program is to move into next phase. Before just a general, there was one question in the Q&A. Somebody asked if this is going to be available after as a recording or something. To be honest, I don't know exactly the answer to that question. Does anybody, does Lynn know, or?
Yeah, this is going to be available as a recording.
Oh, okay. Excellent. Well, at this point, thanks once again, and
Thank you very much.
We'll keep going. Please stay with us, Dr. Koreth, and I'll hand this to Dr. De Lima to introduce to the next section.
Okay. Thank you again, John, and you're more than welcome to stay, right? I mean, but
Yeah.
we essentially, the next step here is basically
She will.
we open the forum for questions from the audience.
Yeah, I'm happy to take questions sort of in whatever format you'd like. I have opened up, I think, for the next half an hour or so.
Okay, so just hang out with us, because
Wonderful, wonderful. Thank you so much.
Let me just do a brief introduction to some of our panel members are not here, or they're joining a little late, but I just want to remind everybody we have the core. I joined this group late during my stint in clinic in Cleveland, right? When I was before I came to Ohio State, so I had the honor of meeting all these good people there, and so the group stands a lot from that core in Cleveland, and then subsequently a few metastases like Dr. Annie M. in Pittsburgh. So we have Dr. Ken Cook, who is now at Johns Hopkins. He's the head of pediatric transplantation there. Originally, he was also at Rainbows in Cleveland before he moved to Johns Hopkins. Myself, as you heard, I am now at Ohio State in Columbus. We also have Dr. Betty Hamilton, who is the interim director of the Blood and Marrow Transplant Program at the Cleveland Clinic in Cleveland. She has been a hardcore Cleveland Clinic person, completing her training there, and has been there for a while. And Dr. Annie, who's you guys see there, she's an associate professor of medicine in the division of Hemonc at the University of Pittsburgh, where we held a very successful edition of this meeting. When was that? Annie, was
I think it was 2016.
Yeah, right. Time flies, man. Yeah, it was a incredibly successful, so well attended meeting. And then she just joined the group. And then Matt Kalasho, Dr. Kalasho, who may not be here today. It's also a founder and has so many links to the Cowdens that I can't not even start to describe. Friendship and medical. But Matt is basically the vice chairman of the Taussig Cancer Institute in Cleveland. And he is an old hand in transplantation with a lot of publications and long experience in the field. Dr. Liu, who also was originally in Cleveland, currently she is an associate member at the Moffitt Cancer Center in Florida. So that's the expat from Cleveland as well. She has a lot of experience as well, including the photopheresis and techniques that use apheresis. And then we have Dr. Steve Pavlevchik, who you see over here. Steve is basically a national leader in the field and has been instrumental in developing a variety of collaborative initiatives that span, I mean, not only the US really, but the whole world towards GvHD. He's the head of the GvHD and late effects section in the Immune Deficiency Cellular Therapy Program, Center for Cancer Research, the NCI and the NIH. I mean, there's too many things here, Steve. You're going to allow me to not read the 16 pages I have here, please. But he's originally from Croatia, and then went to Fred Hutch, and subsequently was in Nebraska when the NIH recruited him back in 2002, right? Yeah. And then since then has been, as I mentioned, a real leader in the field and allowing this field to grow by leaps and bounds by calling the attention scientifically, personally, and on a compassionate basis also towards the patients and making patient-oriented research a priority in the nation. So it's been pretty cool. And then there is Dr. Hannah Cho, who I'm not so sure is joining us, but Hannah is my colleague at Ohio State University. She's a transplanter and assistant professor of medicine at Ohio State. She is a young rising star as well in the field and very dedicated to the graft versus host disease. She's creating now a GvHD clinic and a GvHD specific program. She has an R01, an NIH grant on GvHD, so she's getting very, very much involved. So that's the panel. And now we just added Dr. John Koreth as well. So we're open for business.
Thank you so much, Marcos, for those nice introductions. So we have questions that were submitted by the attendees. And so this is a combination of clinicians and scientists, as well as patients and family members. So really kind of running the gamut in terms of diversity of questions. But so I will kind of go through them by category and we can tackle them as a panel. And if there are other questions that people in the audience have, please feel free to submit them and we can answer them here live. So to start off, and again, I think a lot of the questions were along similar themes, so I'll kind of go by theme. So one of the themes of the questions is when will graft versus host disease end? You know, does this end? So a couple of questions that kind of related to this. You know, will this ever go away? At what point do you see the quote unquote burnout? How long does GvHD last on average? Is the longevity of GvHD impacted by length of time from transplant to first onset of graft versus host disease? So what do you guys think about that?
Who wants to start?
Well, maybe I can jump in, at least my understanding, and
Yep.
Please correct me. I want to learn as much as I want to, share. Is that, really a lot of my understanding of chronic GvHD in terms of long-term outcomes is really shaped by the work from the Fred Hutch. Mary Flowers and her group have really reported on sort of the long-term outcomes of chronic GvHD. They've defined this failure-free survival, for instance, as a new way to read out response to GvHD. And so my understanding from looking at that data is that indeed chronic GvHD is chronic. It is a chronic condition that if you look at 7 years after the onset of chronic GvHD in patients at that point, so patients surviving to that point and captured in their data sets, about a third of patients have kind of burnt out, quote unquote, and they actually report, the manifestations are not active anymore, which equally suggests that, a significant number do not burn out even at 7 years. So there is the possibility of burnout. There's a reasonable probability of burnout in certain manifestations, often skin and subcutaneous sites of involvement, for instance. My understanding of lung involvement in particular is if it is indeed active, it often tends to just be relentlessly progressive, and that is part of why there is such an increase in the mortality risk from active lung involvement with bronchiolitis obliterans as compared to many other sites.
So if I can make just a brief comment is, so for the patient's perspective, and that's how we talk to our patients in the clinic, as you know, all know, is that there's the light at the end of the tunnel, and then ultimately chronic GvHD cools down and goes away, or is much better, controlled. And the peak time and when it's most active disease is usually the first 5 years. The reality is that with the improving outcomes of allogeneic hematopoietic stem cell transplantation, that we're such an larger and larger population of patients they're cured, right? They live long years and many years after bone marrow transplant. I'm saying this because that was not the case maybe 20 years ago. We are learning about intricacies in different populations. In older patients, they were beyond our reach, 70 and up, learning about kids. So something is happening currently in terms of our goal has been for years, start immunosuppression, start corticosteroids, and then taper to try to get them off. And we have to get them off steroids because they're so toxic, right? But we're getting new drugs. And what we are learning that maybe we have to rethink the way treat with getting new drugs. They're more tolerable, they're more practical to take an open-ended manner, that maybe we should be rethinking approach. And one of the goals would be longer maintenance, of tolerable drugs. It's just a vision that I'm not saying that we are there like we are doing for other autoimmune diseases. So maybe there is some paradigm shift happening. We all need to carefully assess that maybe this just pressure, taper off with better drugs. Maybe we should be needing to reconsider our treatment's durability.
Yeah, I would totally support that, Steve. I think that much of this data is quote unquote outdated, because by definition, long-term outcomes means you're running many years behind the current state of the art. And these novel agents, I would hope, actually have disease-modifying potential. So you're expecting that the natural history, the trajectory of the disease, as well as the longer-term tolerability of treatments, more selective immunosuppression or use of immune modulation as compared to immune suppression, these would all be ways where you could indeed continue much longer-term treatment. And again, the analogy with insulin comes in, right? The idea that why would I take a diabetic and stop the insulin at the end of year 1 and then say, oh my gosh, the fact that their diabetes is back means, insulin doesn't work. So we're setting ourselves up for failure if we just use the steroid paradigm and keep trying to get people off. If they're tolerating a novel agent, which is indeed much less immunosuppressive and much more tolerable, then maybe we should just leave them on it at the lowest dose that is actually therapeutically effective, and then look at the biology and the natural history of disease.
Now, I want to add that just to the comment, one of the comments in the question, or part of the question. I mean, do we see a few patients in which GvHD just burns itself out? And the answer is yes, right? I mean, I've seen patients, there seems to be something with that mark between 5 and 8 years. And this is totally anecdotic and not a scientific, but certainly a personal observation that I'm sure you folks share, in which all of a sudden tolerance is achieved, right? I mean, and you can see the person start needing less and less medications, and sometimes can get off completely. The hard thing, as you heard here, is that it's very difficult to predict who those people are and why that happens for Joe, but not for Paul, right? But there is such a thing as GvHD burning itself out. And I just wish I could give a more straight answer in terms of could we capitalize on that and learn how to do it ourselves? That's what you're hearing, how difficult that is.
Yeah, thank you all for those outstanding answers and interesting comments. You're right. I mean, it's something that happens and frustrating, I think, for patients who are, it sounds like, are likely the people who are asking these questions, that we can't predict, we don't know who and when, and it's a lot of trial and error. So, I think that's also a really interesting thing you guys bring up about the paradigm shift of treatment, that we're always, our goal is always getting people off, and maybe with these these newer therapies, that may not have to be the philosophy anymore. And perhaps we can prevent, keep people on long-term and prevent relapses, recurrences, and things like that, progression. There was another question about, if GvHD happens the first time, will the pattern of further episodic appearances be consistent with the first, or can it morph into a completely different presentation? There was also a typed question about that. So I did try to address some of the typed questions earlier, that, a lot of times it does recur in the same organ, but chronic GvHD as a chronic disease does progress. It can evolve and affect other organs down the line. And again, it's really at this point, an area for research, it's impossible to predict who's going to get what organ involvement, et cetera. And then somebody asked about, are there any long-term clinical studies looking at the long-term progression or evolution of GvHD in a large cohort? I'll say that there's 2 such existing studies, and if there are others, please let me, 3 that I can think of. So there's the CIBMTR, which is a large, international database of transplant data that transplant institutions submit data to, and that's where a lot of research has come from. A lot of questions are asked that we probably couldn't answer in a single or even a kind of multi-institution way. So there is that. In terms of GvHD specifically, there is the Chronic GvHD Consortium, which is also a collaboration of several institutions that has data that's being collected sort of in a prospective way. And then there's the Steve's natural history study at the NIH of patients with chronic GvHD, although that's not so much of a longitudinal, it's more sort of cross-sectional. But anyway, this is, those are all good questions. Since we were talking about new therapies and sort of the potential paradigm shift, I guess it's a good segue into the treatment category of questions that people had. So some of the questions people had were, what type of GvHD is Rezurock or belumosudil good at treating? And what is the major difference between Jakafi and Rezurock? Anybody want to tackle that question? Marcos, since you're unmuted.
Hold on. Oops. Oh, here we go. So the difference between Rezurock and
Jakafi, and then what type of GvHD is Rezurock good at treating?
No.
And actually, Marcos, while it helps, if you're while you're talking, I can pull up the study and that really nice figure that shows the organs and the responses. So give me a second.
Okay. While you do that, Jakafi, it turns out to be very interesting in terms of inhibiting inflammation, right? It is a super duper anti-inflammatory drug. And in great part because of that, it has multiple effects in the GvHD, and it has been a very interesting, especially for gastrointestinal, for GI. GvHD has been helping not only taper steroids, but also seeing responses with an oral drug, where we used to see responses only with tons of steroids and intravenous steroids and things like that. And however, it does not have a whole lot of effect in fibrosis, as it seems to be less effective for organs that may have more scar tissue already, or as we say, sclerotic changes. So it seems to be less effective there. So there comes the new kid in the block, right, which seems to have, for the first time, some interesting effect in some of this. Which one is this one?
So this one is from the belumosudil paper, just showing the organ responses. So in blue, it's the complete responses, and in red are the partial responses. So for that question.
Yeah, you see a lot of solid responses in the gastrointestinal tract, right? But less so in the fibrotic setting for the new drug, for Jakafi. The new drug seems to have a slightly different spectrum, and there's a lot of hope towards organs that have more fibrosis involved, more scar tissue involved.
Now, maybe I'm going to ask a question to the panel. Do you have a preferred drug in someone who is steroid refractory, say with fairly classic sclerodermatous involvement of the skin and some subcutaneous joint muscle fascia involvement, a bit of dry eye, a bit of dry mouth, keeping it simple? So steroids alone don't seem to be getting them to quite what they need. Do you have a preferred sequence or preferred next drug, recognizing that we have 3 approved agents at this point in this space? You know, I can certainly say my own selection is not, you know, in part it is structured on the toxicities of the treatment. You know, what are the side effects expected for the one versus the other versus the third? You know, what is the copay that the patient might have in terms of their insurance? So sometimes that plays a role. And to some extent then, you know, what is the expected, you know, frequency of their need to come back to the clinic on the drug.
Right.
So it is not truly focused on, oh, this person has a JAK1, JAK2 type chronic GvH versus that person has a ROC2 flavor of, you know, I don't know how I can predict which one, you know, all of them, to my mind, in terms of headline response rates, have all reported 60+% response rates in a selected study population. There are no head-to-head comparisons, of course, for obvious reasons. There may never be a formal trial comparing one versus the other. That's just not how trials have been structured and supported in the past. So then we are left with these secondary readouts to kind of say, okay, let's start with this. If this works, great. If it doesn't, let's move to the second agent, to the third agent.
So we could go around the table, and so it's definitely, these are the excitement. These are 2 different targeted therapies, molecules that medications that can be taken orally, you know, long term. It's very attractive, right? Comparing to some others, like, you know, that need more intensity, like extracorporeal photophoresis. The paradigm has been until now really that we didn't know. Second line was more relative to these other constraints that Dr. Koreth mentioned, the logistics, the costs, the preference, the side effects profile. We are just starting to get into some kind of early dawn of me being sort of like driven, like where should we go, based that we do have very exciting and tolerated drugs, and that even although kind of in a timid way, but national guidelines, NCCN, the first, like last September, put like ruxolitinib in the category 1 choice, you know. So that's that's totally new. Until now, everything was just physicians. So we do have some kind of outline where we should go. The ruxolitinib is approved for the failure after frontline therapy. The belumosudil after 2 or more. So this is a little bit indication, right? Ibrutinib was approved for 1 or more, but it's an older kind of drug in the realm of chronic GvHD, and there's been with the longer application, it seems that durability of these responses in real life is not as much as it was described originally. So in terms of ruxolitinib, belumosudil, or some, those 2, what Dr. Koreth said. It's belumosudil still maybe like a third in the current algorithm, unless there is some toxicity concerns, because ruxolitinib, we know cytopenias, infections, with belumosudil. I have to say, probably hope everybody, I wonder what others think, it's really very well tolerated, sometimes some liver side effects, GI, but it's the tolerability profile is really outstanding. And I don't think we have strong indication that's saying that any of these two should be better for one manifestation or the other.
Yeah, I believe Dr. Zeisser might have actually made a presentation at this seminar series. So I'm sure he was the source for it. But as you know, I think that's a very important point. The quality of the data supporting the indication, ranges from single-arm studies, prospective trials, obviously, to randomized trials. And so we consider randomized trial data to be stronger. And in that regard, the Jacophy trial design was indeed Jacophy versus best supportive care in steroid refractory patients in a randomized prospective evaluation, as compared to perhaps more advanced patients in a single agent, single arm study with both ibrutinib and with Rezurock.
Yeah, so for that reason, I'll tend to go with Jacophy first, also because of the insurance concern. And that's just a logistic thing, that, since Rezurock's approved for third line, technically, that I'll, usually use something else first.
I think what we don't have is a readout of your pattern of GvH or your blood biomarker profile tells me that you are enriched and more likely to respond to a JAK1/2 inhibitory drug versus a BTK inhibition versus ROCK2 inhibition. Right? We don't have that quote unquote scientific or clinical thing to guide us. It's more, how was the drug approved? In what setting was it approved? So let me stick to that. Since we know that all active drugs, the sooner you start them, the more likely they to work. It's quite plausible that if there was a belumosudil frontline or a first line failure study, that'd probably still be positive, and then we would move our usage accordingly.
Oh, absolutely, right. And I think the other thing, we've seen responses in all of those drugs, across organs. And so we don't, there's not, again, as everyone has said, there's not one particular setting where we choose one over another. It's sort of, it's, taking a moment to pause it. It's this luxury now, right? You guys have been doing this longer than I have, but it's amazing now to have, numerous options, or at least, a handful of options, as opposed to kind of older therapies, phase 2 studies, single arm, don't know what's best, a lot of side effects with the older drugs. I think the tolerability of the newer agents is something that's been really refreshing, but just having all those options, I think, is great. It's novel. Well, I can move on to sort of research category of questions, I guess, that are kind of related. So there was one question about what are you seeing in clinical practice regarding chronic GvHD trends, more, less, or same number of patients? And then a question about what is the current status of development of biomarkers for early diagnosis of chronic GvHD? Steve, do you want, Marcos, go ahead.
Okay, John, I see your comment. So I think that GvHD, it's still there, right? I have to say that, right? It is still a problem that's very prevalent. Interestingly enough, it is possible that some of the new graft versus host disease prophylaxis prevention strategies may be better in some settings. So for example, right, we have to mention the post-transplant cyclophosphamide approach that seems to be associated with less chronic graft versus host disease. That said, obviously, there are other other issues that may come, right? I mean, as we all know, there are different spectrum of side effects for each intervention that we do. And if you're a patient, you know that very well. It is never a completely free lunch in dealing with these complex situations. However, it is emerging that the rates of chronic graft versus host disease after using this doses of cyclophosphamide, this a new old agent being used in a new scenario, if you would, post-transplant, may be lower than in other scenarios. There is a forever issue in our field, which is one of the few randomized studies comparing bone marrow as the source of stem cells versus peripheral blood, show that if you use bone marrow as the source, you end up with less chronic graft versus host disease as a ratio, right? However, it is very hard to expect that the field simply cannot keep up with the number of transplants and collect bone marrow on every single transplant. And the reality is that we end up using a lot more of stem cells from the blood. And these stem cells from the blood are intrinsically associated with a little bit more of GvHD. So these are things that have been around, but are not easy solution, obviously. I don't know if the others want to pitch in more.
So, just to emphasize, we actually have some trials that are ongoing, right? Comparing post-transplant cyclophosphamide versus our standard of care transplant. So that, I think, will be an exciting, hopefully definitive phase 3 trial, which will tell us what would be the optimal anti-graft versus host disease, because post-transplant cyclophosphamide really can reduce the risk, particularly of chronic graft versus host disease and severe acute GvHD, both for haploidentical, but now pushing into both mismatched and HLA matched donors. So I think that brings it more into the mainstream.
Yeah, if I can comment, obviously, it's well established nowadays that we have effective methods of decreasing incidence, occurrence of chronic graft versus host disease, post-transplant cyclophosphamide, T-cell depletion, anti-T-cell antibodies. It was mentioned before, we are still not doing that well in identifying a patient before transplant. Where's the risk profile, that who may benefit more from this kind of approaches versus less. Clearly that most studies, actually, I would say all studies that addressed anti-T-cell therapy, there was an important decrease in chronic GvHD, but it was not so clear relative to survival or relapse rates and so on. So it's lots of work to be done in terms of personalizing approach in prevention. And actually, there's one project that Dr. Im is spearheading, may be developed through CIBMTR, try to prognosticate better at the baseline. That moves into this question about biomarkers. Can we early diagnose? And that's a great question. It's really bothering us a lot. It turns out it's been much harder with chronic GvHD than with acute GvHD. And that one was not easy either, but because there's such a diverse clinical presentation, a heterogeneity of patients, long trajectory. So it's been harder, but there's a clearly good list nowadays of candidates, whether some soluble potential biomarkers like cytokines, chemokines, and others, cell subsets, so cellular biomarkers, or even recently been more interested in tissue biopsies for early diagnosis. That's been a really hard area, but so a very active area of research. We would like to if we develop better these approaches, we may be better in early intervening with some of these less toxic drugs. And the other side of this coin is trying to learn when to taper immunosuppression versus not. It was a prior discussion, is chronic GvHD burning out? And we don't have a litmus test, to say, okay, now you can stop immunosuppression. These are very active questions, including the one like which drug should be given to a specific patient. So we really have great hopes for biomarkers, but we'll see if that gets fulfilled. I hope it will.
Yeah, a lot of work still that needs to be done. Well, we've made a lot of progress. Another question kind of related to treatment now is, what's the standard of care for early diagnosis and management of pulmonary GvHD? Has there been any forward progress in the last few years since Jakafi was approved for treatment of lung GvHD? And if so, could you elaborate on some of those treatments?
Can I go back to Dr. Im and ask her to address this question?
Yeah, and I was gonna say it's too bad that Ken Cook isn't here because I know he likes this topic too. But I will say that there's not been any, kind of advanced progress in terms of specific treatment for lung GvHD. In terms of early diagnosis and management, what we do is we screen patients after transplant for symptoms, but also using pulmonary function tests and looking for any decline in some of the pulmonary function test numbers, specifically the FEV1. Typically what patients will start off with is, with any, it's lung GvHD as of right now is treated like any other chronic GvHD where you have some underlying, systemic therapy for the underlying process, which is immunosuppression. And then if there exists some organ-directed therapy as well for symptomatic, improvement, that can also be started. So for lungs, in addition to steroids or whatever systemic therapy they're going to be started on, there is FAM or fluticasone, azithromycin, and montelukast, which is a standard therapy that has been studied and has shown benefit for initial treatment of pulmonary GvHD or lung GvHD. Steve and I have a study that's been conducted at the NIH with a new agent that's called alvelestat. The way that it works, it's a neutrophil elastase inhibitor. Neutrophil elastase is an enzyme that causes damage in the lungs. In normal settings, it can help with anti-infective and reactions, inflammatory reactions in the lungs, but left unchecked, it can cause damage. And so there's some data to support that that's involved in the pathogenesis of early BOS. So this neutrophil elastase inhibitor is a pill. It's really well tolerated. So we've looked at that as monotherapy, as therapy by itself in people who have more advanced lung GvHD. It has shown that it's been able to stabilize the disease in some settings, but that's a very early signal and we can't make that conclusion as of yet. The study that we did was just an early safety study, and it does look like it's very well tolerated in patients who have chronic GvHD of the lungs. So we're doing further studies on that, but it is, as far as I know, one of the few sort of lung-directed therapies that have been studied. Otherwise, I think people are hoping that some of these novel therapies will also help treat the lungs, but it is, definitely an area of need in terms of research, because it is, obviously when it's affected, it can be very severe.
So I'm sorry, Marcus, go ahead.
Oh, no, I was just going to make one comment, which is today, I think that the most solid recommendation still is you gotta be monitored, right?
Yeah,
if you're
exactly.
A patient, we tend to relax. I mean, it's normal. After a while, the last thing I want to do is keep seeing Dr. De Lima, forever, right? But the truth is, those pulmonary function tests are still the best way to evaluate if your lung, one person's lung capacity is changing. So I tend to, I don't know about you folks, but I tend to recommend my patient to keep doing PFTs, pulmonary function tests, forever. Maybe we relax a little bit after a few years, but the truth is I keep telling them, oh, I want to see a pulmonary function test every year, maybe every other year when things are very stable. In the beginning, I try to do them actually relatively often to not get a sense of security that nothing is happening. That's my 2 cents on that. And, it's to early detection, it's still the best because the lungs are so hidden, right? I mean, once you have symptoms or severe symptoms, it's a lot of problem already, right?
Yeah, I want to just say the same thing. It's one chronic GvHD or bronchiolitis obliterans is something that by definition is really not reversible. When it happens, discarding of the small airways, it can't go back. So this is why question is, early detection. It's desirable. And as a matter of fact, there is a randomized trial in mild BOS, those with FEV1 between 60 and 70 from France. Very good data, placebo-controlled, inhaled corticosteroids with the beta agonist, showing significant reversal of early BOS with a simple intervention. Unfortunately, I don't know why is that not happening. We are having studies for lung patients come all the time in the late advanced phases. There's even nothing. We can't even ask the question, if this is going to be helpful. One of the problems, it's rare, right? So maybe 5% transplant patients at risk of developing. We have been fighting for the last 10 years very hard to get these guidelines implemented, that they are published, NIH guidelines that you do every 3 months first year, every six months thereafter, FEV1. We've been getting incredible pushback from all kinds of sides, how this is complicated and expensive. Really? And so it's still happening, all the time. We get these referrals, they come very advanced BOS, and even if it's not being diagnosed. So I don't know what's going on, but what Dr. De Lima said, early detection, there's some indication. We know very well, actually, that earlier phases respond better to systemic treatments as well. Hopefully these trials would move forward. I know there's some funded trials. Even I think CTN is planning with the home spirometry, that maybe patients can apply and detect early fall, because people say, like, I feel great, right? Well, it takes, you need to lose 50% of lung function before maybe you start having symptoms, and there's no way back.
Right, so absolutely, I agree. Sometimes we'll see a decline in the FEV1 early before somebody has symptoms. And so you're catching that and you're able to intervene before someone develops things that impact their quality of life or their functioning, because you're right, Steve. I mean, sometimes when people develop symptoms, they're already down to, 30, 40% FEV1, which is low. So I definitely agree with the screening. And I've never had a problem, I don't know about you guys, in terms of insurance not covering it. It's always been covered. It's always been smooth process in terms of that. So there was a question about ECP. I wish we had Dr. Liu with us, but about being referred to a dermatologist. And so the dermatologist, I guess, and also in something by an MBMT link had recommended ECP, but then this person's doctor was skeptical because they felt that the treatment was too long and arduous rather than, compared to how effective it might be. So they wanted to get our thoughts on that. So thoughts on ECP.
Hold on, guys, I'm so sorry. So could you please, I had to, I got a little distracted.
No, okay, basically the question was about ECP and, some clinicians feeling like this is long and arduous as opposed, rather than effective, and, our thoughts on that.
So I'm going to give a ECP. In my view, you only see the value when you stop it. people say, this is not doing anything, this is not doing anything, until the day you stop, and then things flare. So clearly, it is an immunomodulator, right? As you heard, Dr. Koreth even used that word for ECP, and I think has a role. And I don't think, please, you folks interject there, but I don't think it works as well for gastrointestinal. But there are some skin manifestations, maybe some, even the lungs. Occasionally you can see stabilization of the treatment. So it's very individualized, but there are two caveats. It is logistically demanding because of the need frequently for a central line, or, very few patients have peripheral access, right? So logistically, I understand is very demanding on patients. And there is fatigue, right? Doctors fatigue, hospital fatigue, insurance fatigue, patients fatigue. So it is all but easy. However, we all have seen, and I would call my colleagues here and even patients that may be in the audience, in which we come to the conclusion, oh yeah, no, it's not doing anything, we've done this long enough, and then we stop and you see the symptoms return. And so clearly it has a role. It's just hard to preconize it for everybody. Simply, some people don't even live close to a place that can do it. So that's my two
I agree.
cents.
I agree.
I agree. It is, it's tedious and it's time consuming, but, other than that, the side effects are pretty minimal. I agree. The logistics are really the biggest sort of aspect of it, but otherwise it can be really effective. I have patients who love it. So unfortunately we are out of time, and that'll have to be our last question. But thank you so much, panelists, for joining me and answering these questions so thoughtfully. And for the participants for submitting questions, and I'll hand it over to Meredith.
Thanks, Annie. And I want to say thank you to everyone for participating in this, especially thank you to Marcos, Annie, and Steve, and Dr. John Koreth, who had to step off a bit earlier because he had some patients and some things that he had to attend to. And so I just want to say again, thank you so much, and a special thanks to our sponsors. Again, I have to say, thank you to the James at OSU, the Cleveland Clinic, Sanofi, Syndax, Pharmacyclics, Janssen, and Insight. Thank you so much for your support so that we're able to do this. And thank you to the committee at large, the ones who couldn't be here today. And I'm just going to mention them again real quick. We've got Matt Colicchio, Betty Hamilton, Heen Liu, our newest member, Hannah Cho, Ken Cook, and especially thank you to Lynn Hazelton, who is not visible, but is a huge part of this and does such a wonderful job. And thanks to Nick Galarakis for his technical work and his ability to do all of this. I value it and appreciate it because I couldn't. And also I would like to say thank you to my parents and all the hard work and all of the, all of the dedication that they put into this. And finally, I think, I want to say, I personally really appreciate, even though he's not here, and I'm just gonna, thank him anyway. Dr. John Koreth did such an amazing job on his presentation. That was phenomenal information, and he, I'm so interested in what's going to happen next and where all this information is going to go. And so finally, then last thing, and then I'll wrap it up and let everyone have a good Friday, is I'm just gonna, put it out there that we would love it if you would join us for the next two parts of this particular series. On October 21st, we have Natalia Buxbaum, who's going to discuss the biology of graft versus host disease and, potentially the concept of personalized therapy, which I think is, something that is very interesting, and also something that was, touched upon a little bit today, and what to use and how to approach things, and what are the difficulties associated with it. And then also in January, on January 27th of 2023, we're going to have Joseph Padala, and he's going to discuss how to choose drugs for graft versus host disease. And then finally, at some point to be determined in the springtime of 2023, we're going to have a more patient-oriented conference and discussion. So please join us then. Thank you so much for joining us today. Thank you to all of you, and have a great weekend. And we'll see you soon. Bye.
Bye-bye. Bye-bye.
Bye-bye. Thank you. Thanks, Meredith.
Yeah.